Thank you very much. Thank you for the organizers for inviting me to talk. And Elizabeth, I fear the postprandial dip is probably starting in around now. So first, my apologies. I really thought long and hard of a snappy title for this talk and really came up empty. Dose-dense chemotherapy for frontline management of ovarian cancer. Really trying to make this topic real exciting. I didn't start with the title, but stick with me. We should make up for it with the rest of the talk. How do I move forward here? Okay, so disclosures. So the objectives here are really to put dose-dense chemotherapy in context with the other therapeutic advances that we've made in frontline management of ovarian cancer, to explain the rationale for dose-dense chemotherapy, and to really dig down into the data from randomized controlled trials of this concept. So. Not so much learning questions here, but I guess just a poll question. In your practice, what is your most commonly used chemotherapy regimen for frontline management of high-grade serous ovarian cancer? So I've listed carboplatin. You can choose AUC 5 or 6 with Q3 weekly paclitaxel, the same carboplatin but with weekly paclitaxel, the combination of carboplatin, paclitaxel, and bevacizumab, an IP chemotherapy, and if you want to put something else in there, you can put something else. So we'll take a minute to put things in there. All right. I was going to call out the something else if that showed up. All right. So okay. So majority the conventional Q3 week carboplatin, right? Okay. So second question. In 2008, have you prescribed dose-dense chemotherapy in frontline management of ovarian cancer? Yeah, that's should be a simple yes, no, but I've left a not sure if you want to, so go ahead with that. Okay, good, all right. There will be a follow-up question to that. Okay, so the rationale for dose-dense chemotherapy. So we're using the same drugs, we're just giving them in a different schedule. What's the deal there? So really, there's laboratory evidence to suggest that the frequency of delivery of many chemotherapy agents, taxanes being one of them, you could say the same about anthracyclines, it may have an enhanced anti-apoptotic effect, and I think more interestingly, an anti-angiogenic effect. If you want to look at what is important in terms of, over the course of 18 weeks, giving a greater dose over the course of treatment at the expense of a higher peak concentration, there is suggestion that perhaps the higher dose overall is what is more important. That's all theoretical, but in the clinics, what have we seen? Certainly in some, but not all malignancies, certainly breast cancer, we know in the adjuvant setting, dose-dense chemotherapy has shown a survival advantage, and that's standard of care in the adjuvant setting, and higher response rates we've seen. Certainly weekly paclitaxel in advanced ovarian cancer is a very active regimen as well, and certainly phase 2 studies done early in 2000s demonstrated activity of the carboplatin weekly Taxol regimen, which warranted further study. Okay, so really I wanted to just put into perspective all the innovations, in the last decade, frontline management of ovarian cancer. So not in any particular order here, and my apologies to those if study is not represented in my little graphic here. So the use of intraperitoneal chemotherapy, delivering the same chemotherapy drugs, just in a different way, different timing, neoadjuvant chemotherapy. Where's Deanne? Sorry, Deanne, I forgot. The Dutch HIPEC study, yes, I know. It should be right there, I'm sorry. It will be there the next time I revise the slide. Then the incorporation of bevacizumab, certainly in 2011 with 2 studies publishing at that point. This is the focus of my conversation here, and the 4 studies that I'll go in sequence in terms of dose-dense chemotherapy. So I think admittedly there is still work potentially and still some unanswered questions with all 4 of those interventions, yet we're moving headlong now into newer agents into this space. So PARP inhibitor studies like SOLO-1 and PRIMA are occupying our space. Those are studies that are either closed or ongoing, and we're still going to get readout of that over the next couple of years, and we're moving headlong into the IO space in frontline management. So still some unfinished business, as I've said. The boxes in white are still studies that need to report out in these various spaces. The dose-dense chemotherapy has been incorporated as part of the standard of care in some of these clinical trials. I won't talk about those. Really, these are the 4 studies that will make up the bulk of the remainder of my talk. And it really starts with this one. This is Katsumata, the JGOG 3016, which was published in 2009. Okay, so 2009, I don't view myself as too young or too old to say that 2009 was that long ago, but I think it's just to reflect on, where we were at in 2009. This is when this study came out. So what was going on in 2009? So all of these things, if they existed, we certainly didn't use them very much, and now we're using them all the time, all right? So Facebook, Snapchat, Twitter, not really much of that in 2009, but that's a part of our daily lives now. All these phones that you have, we're using for the poll question. iPhone was on iPhone. There was no iPhone 3 yet. There was no. Now we're on iPhone X, right? So, and that's the one on the right. It didn't really look all that great. And then emojis. That was an emoji in 2009. Now we've got emojis out the wazoo, right? So, the world is a little different now compared to 2009 when that. So here's this was Rob Coleman's not here. This is right for him. So Barack Obama was just elected president, and he looked like that in 2009. And then he looked like that towards the end, right? And so I promised myself a Trump-free presentation, so I won't even go there. I had a slide about Justin Trudeau. He was closer to being a teacher in 2009 than to Prime Minister, but anyhow. But more importantly, from the ovarian cancer world, the drugs that we're talking about a lot in ovarian cancer. So in 2009, this was publication of the phase 1 study of olaparib, July 2009. Now it's really front and center for us. I guess, this is 2010. This is the first phase 1 study of PD-1 inhibitor, this Medirex compound, which bought out by somebody else, bought out by, this is now Opdivo. A lot has changed. This is a long way of me saying a lot has changed since 2009. Yeah. So the paper. So this is the JGOG study from Katsumata. The arms, as you can see here, conventional chemotherapy with Taxol and Carbo every 21 days compared to the dose-dense regimen, a weekly 80 milligram per meter squared, with the primary endpoint being progression-free survival. I'm going to go through these pretty quickly, so just some baseline characteristics to note, and you can compare across the 4 studies that I'm going to present. So in JGOG 3016, it was primarily stage 3 and 4 patients. There was a significant minority of stage 2 patients. It was balanced. Interestingly, serous was less than 60%. I think that's worth noting. Residual disease status, they broke it down by less than 1 centimeter or greater than 1 centimeter, and it was about a 50-50 split. You can see as well that it was that fewer than, most patients completed treatment, but in the dose-dense regimen, 38% did not complete 6 cycles of protocol therapy, slight imbalance there. In terms of toxicity, so this is grade 3 or 4 toxicities that were listed. You can see that in the dose-dense chemotherapy arm, there was more anemia, but the other marrow toxicity was similar. Also, they noted similar rates of neuropathy. And so I think that that's, keep that in mind as I go through all of the different trials, that there are some differences across trials in terms of toxicity. It was a higher rate of discontinuation due to toxicity in the dose-dense chemotherapy arm as well. And I think you're all pretty aware of the results of that study because I think it changed practice in many jurisdictions. The progression-free survival is on the left with dose-dense chemotherapy in green, showing a significant progression-free survival advantage. There's definite separation of those curves, hazard ratio 0.71, and that translated into a 3-year overall survival advantage, 72% versus 65% in favor of dose-dense chemotherapy. And worth noting that quality of life was not formally assessed in that study. Okay, so second of the studies to discuss is the study presented, led by the Italian group as METO7. A little bit of a difference here in that they, in terms of the dose-dense regimen, they also fractionated the carboplatin differently. I think that's an important difference. So whereas the carboplatin was kept at AUC 5 or 6 in Katsumata, in the dose-dense regimen here, they gave AUC 2 on days 1, 8, 15 with the weekly Taxol. And they had PFS and quality of life endpoints, similar stratification to the Katsumata data. They allowed stage 1C, but there weren't very many of those patients. So again, predominantly stage 3 and 4 patients, a higher proportion of serous patients in this European study. They documented residual disease either as no residual disease, less than 1, or greater than 1. So there was a good proportion of patients with no residual disease. And you can see the ECOG performance status was balanced and predominantly a good performance status patient population. So with this regimen, this seemed to be better tolerated than the conventional chemotherapy with the significant differences there. As you can see, neutropenia and thrombocytopenia favoring conventional chemotherapy. The rates of neuropathy were also less with the dose-dense regimen in this study, in this patient population. And most patients got through treatment without having to have it stopped, but at least numerically more patients stopped the dose-dense regimen. And in terms of efficacy, though, these curves are pretty much superimposable with progression-free survival and overall survival listed above and below there, really no significant difference. I think interestingly, and it kind of makes sense, the quality of life as measured by the FACT-O score, the Q3 weekly regimen, which we've all seen is patients typically go through a rough week and then they rebound back to their baseline, and this is what is documented on the graph on the right, that their quality of life weeks 1, week 4, week 7 dips down, not so much with the weekly regimen. So there was a statistically significant difference there, but the quality of life extended out beyond treatment really was no different between the arms. All right, so the next trial then, again, still a bit of a variation on the theme. So this is the GOG study that looked at replicating the experience in the Katsumata data, however, with the addition of bevacizumab. Now, bevacizumab, as this study was developing, bevacizumab in other studies showed a significant advantage. So this became an option for investigators to treat patients with bevacizumab. It wasn't mandatory. However, most patients, as you'll see, received bevacizumab. So again, conventional Q3 weekly dosing compared to dose-dense dosing with primary endpoint being progression-free survival. This was reported in the New England Journal of Medicine. Very few patients with stage 2 disease in GOG 262. predominantly serous. The percentage of patients with microscopic residual was fairly low. You can see that those numbers don't, let's see, yeah, so there was a group of patients that received neoadjuvant chemotherapy, so they weren't considered in the residual disease assessment. And 84% of patients had prior bevacizumab going onto the study. When you look at the toxicity between the two, the neutropenia and anemia favored conventional dosing, flip-flops. The neutropenia, higher rates of neutropenia with conventional dosing, whereas the dose-dense had a higher rate of anemia. Neuropathy was slightly worse for the dose-dense patients, and there was 12% of patients that discontinued due to toxicity compared to 3%. Right, so then in terms of efficacy, for the patients, for the overall intention to treat population, it doesn't come out in color, but the top two squares are progression-free survival on the left and overall survival on the right. That is for the intention to treat patient population, no significant difference. Post hoc analysis, though, looking at who received bevacizumab and who did not, suggested perhaps that the bevacizumab was kind of equalizing things. So those that 16% of patients who did not receive bevacizumab, there seemed to be potentially a benefit to the weekly paclitaxel compared to Q3 weekly. That is an interesting observation there. And then the fourth of the studies, which has been presented just in abstract form. So I don't have fancy Kaplan-Meier curves to show you because my pictures didn't really project very well from the talks. So, but I'll show you the top line data from the presentation, though. So this was the largest of the studies. I think it's important to note that. You can look at the number of patients, 500 patients per arm. This was led by the UK and took state patients 1C to 4 and randomized to either carbotaxol, the standard conventional dosing, versus weekly paclitaxel with standard carboplatin Q3 weekly, or fractionating both carboplatin and paclitaxel in the weekly format in arm 3, again with primary endpoint being progression-free survival. So in the groups overall, the majority of patients were good performance status, 72%. Patients overall were serous histology. It was about a 50-50 split between neoadjuvant chemotherapy and interval debulking surgery versus primary debulking surgery. A very small minority of patients did not have surgery. Patients on standard conventional dosing of chemotherapy were more likely to complete all treatment, and you can see the toxicity profile, slightly higher toxicity rates with either of the dose-dense regimens, but not a significant difference in sensory neuropathy across the board. So we can see across the different studies, we're seeing a little bit of difference in terms of tolerance. I'll get back to that in a bit. So when it comes to efficacy, this was reported at ESMO last year. When you look at progression-free survival, the median for the standard arm was 17.9, very similar to what you see in the Katsumata data, but either of the dose-dense regimens, although numerically superior, that did not equate to a statistically significant difference. Because the hazards were not proportional, they felt it best to describe it as a restricted mean rather than median, and even if you do that, the difference is even smaller between the standard arms and either of the dose-dense regimens, with hazard ratio very close to 1. At ESGO, they did give a presentation on the quality of life assessment, and really in terms of global quality of life for the study, there was no statistically significant difference, and patients came back to similar quality of life at the 9-month standpoint, but there did seem to be a difference in peripheral neuropathy scores in either of the weekly arms compared to the Q3 weekly arm, and those differences did, when they just looked at neuropathy, those differences in patient-reported outcome of peripheral neuropathy did continue later in follow-up, which I think is an important point. All right. So, when you have 4 studies which show a little bit of different outcomes, what you should be doing is a meta-analysis. As far as I know, no meta-analysis has been done. So I think if everybody's familiar with, there's a forest plot with anything to the left favors dose dense, anything to the right favors conventional. There hasn't been a meta-analysis as far as I know, so I'm going to do one. And I'll do it a little differently because it's 2018 and we all use emojis. This is an emoji analysis. All right, so starting with the Katsumata paper. Okay, so that's all good. We change our, oh, that line shouldn't have gone all that far. Sorry, messed that up. But that was, we're all happy about that one. All right, then comes along the Mito 7. No, that's the meh emoji, okay? So then, and of course the emoji has to be the size, it's weighted by the size of the emoji. So if you have a larger, that's a more patient, I had way too much time on my hands. All right, so yeah, again, meh, but there was, maybe those patients that didn't get bevacizumab, maybe that's still good. So that's the subgroup of that. And then, unfortunately, the UK study. So then, what do I think overall? Yeah, if you sum all of that up, then you get a thumbs down. And I didn't adjust the skin tone of the... Never mind. Okay, so how do we rationalize all of the different trial outcomes? I think we have to appreciate, and I think we see this in other cancer types too. This is not a unique thing to gynecologic malignancies. That there can be regional variations that account for different trial outcomes in different parts of the world. So the initial paper from Katsumata, that was an entirely Japanese Asian patient population. And we see this in other malignancies, GI cancers, for example. It's very difficult to extrapolate what happens in that in studies that are strictly done in Asia compared to the rest of the world. And why are there those differences? There can be differences in tumor biology. There can be differences in pharmacogenomics in terms of how patients are tolerating the drugs. You can see that one example, looking at the neuropathy differences. So in some of these studies, neuropathy was worse in the weekly arm. In other studies, it was better in the weekly arm. So I think there can be some differences in tumor and host biology, and maybe even from a pharmacogenomic standpoint, and the conduct of the study and societal, cultural norms in terms of continuation on treatment versus not, some subtle differences there. So I think that's all something that we have to appreciate. So what are the costs with dose-dense chemotherapy? Although there have been cost-effectiveness analyses reported based largely on the JGOG study, but there has been one done of the GOG 262 that suggested that dose-dense is cost-effective. I can say, well, really, the cost of paclitaxel is next to nothing, so that's not so important. But in this time where we have stresses on our infusion centers. A patient coming in 18 times compared to 6 times puts a stress on our infusion center, and it puts the burden on patients to bear the cost of transportation back and forth. I'm not sure how well those were captured. So it's certainly a costlier and more resource-intensive regimen to have to use, which is fine provided that we are very clear that it is beneficial. And in terms of toxicity, again, it's different in the different studies, but I think that certainly what my experience has been, and I think the experience that seems pretty clear in all the studies, there does seem to be more hematologic toxicity, particularly anemia with dose-dense, and certainly neuropathy. I think the largest of the studies, the ICON 8, I'm impressed by the fact that patient-reported neuropathy was worse, and that extended out long beyond treatment completion. So I would be concerned about that. In terms of future directions, the only study that has reported on overall survival is the Katsumata paper. So perhaps longer-term follow-up for the other 3 studies for overall survival are important. There are still 2 ongoing randomized trials, the ICON 8B. Exactly why they're continuing on this, I'm not really sure, but that is looking at bevacizumab. So they're doing the same comparison, carboplatin Taxol in conventional doses compared to weekly paclitaxel. They've taken, in ICON 8B, they've taken the carbo AUC2 weekly arm out, but this is with bevacizumab for all patients. The IPOC study is comparing IV dose-dense chemotherapy with the intervention being IP chemotherapy. So it's IV versus IP, but with weekly Taxol in both arms. And I think there's an important, with all of these trials, I think there is important translational and biomarker research to be done. I think that, in an age of personalized medicine, it's probably not fair to say that one size fits all, and there very well may be a patient population that would benefit more from dose-dense chemotherapy than others. One example, coming from the GOG 262 study, there was a sub-study that Ting Li, who's an imaging scientist at Western, played a pivotal role with the Akron group. And they essentially did dynamic contrast-enhanced CT in the hopes of establishing this as a functional imaging biomarker for patients on frontline therapy. So in a nutshell, they did these CT scans before and after treatment and could configure the imaging to represent blood flow and blood volume. And sorry, I'm not sure if this projects, but there we go. So with this particular patient, so the drop that they saw from baseline to this first or second time point, that drop in blood flow and blood volume represented patients who had that type of response in drop in blood flow and blood volume. That was a prognostic factor. So the hope would be that that would be something that could represent a functional imaging biomarker, and that seemed to pan out in the patients that were participating in this study. The downside to that one is it is dynamic, so patients have to be on a treatment. You have to have them on that treatment. It's not necessarily a biomarker you have at baseline to choose your direction in therapy. But there are other examples too. The biomarkers of genomic analysis in the ICON 7 study with bevacizumab, that would be one example of a predictive biomarker. Okay, so I think this is pretty close to my last. So I guess my conclusion, and we can have discussion on this, I think really despite the early randomized data from JGOG, the 3 subsequent randomized trials really failed to validate the benefit of dose-dense chemotherapy over conventional chemotherapy in a Western population. In the frontline management of ovarian cancer, I view it as more resource intensive. But that's both for the system and for patients. It does appear to be associated with more neuropathy and anemia, and possibly worse global quality of life. That's what was suggested in some, but not all studies. I don't believe that it is associated with a clear improvement in efficacy, which is why multiple studies have to be performed. So, with that, now I'll ask you, will you prescribe dose-dense chemotherapy for ovarian cancer in frontline for the rest of 2018? So, yes, no, or not sure. Yay, I did good. I made some people not sure. Remember, it was 50-50, right? So anyway, there we go. And that, I think, was my last slide. So I'm happy to answer any questions. Thank you for your attention.
So, Stephen, have you stopped giving dose-dense in London?
Yes.
Okay.
Have I stopped giving dose-dense chemo in London? Yes. You can ask
you have control
Dr.
over
McGee, who's over there. No, pretty much that's what we've done. I think the results of ICON 8 really influenced us to make that change.
So the other interesting thing is the neuropathy. So I've often given, when people get significant neuropathy on a Q3 weekly, switch them to the weekly, but the data here suggests that that's probably the wrong thing to do. So,
And I'm not, I'm not sure that one size fits all either, because the data was, as I showed, it was sort of inconsistent across the different patient populations that were studied internationally. So.
That was a good talk, Stephen. Thanks. Even though, anyway.
Spit it out.
Question. Okay. The patients that were studied, these are patients who were upfront debulked. No?
Some patients had neoadjuvant chemotherapy, depending on the study.
But is there a good study that really teases out the neoadjuvant versus upfront debulked? Because I think we're sort of comparing apples and oranges to some extent, right?
It's a good point. It's a good point. I think, yeah. I thought, yeah. Yeah. So I think that, I think the others, that may be a criticism of the other 3 studies. So you could say, so, I mean, that could be, but I think still, yeah, I mean, I accept that. That's a reasonable point.
So Steve, how do you explain in the GOG trial that the patient that got dose dense without BEV basically did better, and if you add BEV, it basically eliminates that? Could that be part of that angiogenesis issue?
Yeah, I mean, I think that was really, yeah. I mean, I think, and maybe I'm a bit premature, because I think that my feeling before ICON 8 came out was that there was an anti-angiogenic effect here, and that weekly Taxol is poor man's bevacizumab. But then when ICON 8 comes out, and so perhaps what we need to do is to wait the full publication of that. So there may be some details there that haven't been presented in abstract form. I think that's one thing for sure.
The only thing I'd point out, Walter, is the use of bevacizumab was not randomized. So it was a physician, patient. The use of bevacizumab in that study was not stratified. It was up to the physician and patient whether they wanted bevacizumab or not.
It was a stratification factor, but it wasn't randomized. Yeah, so there could, who were the patients who didn't receive bevacizumab? Was there some other confounder there? That's, yeah.
Is there like a subset of patients where you would see an advantage of still using it? Like after interval debulking, if you have gross disease remaining and you don't have access to BEV, would that be a subset?
Yeah. I don't know. I mean, I think it would be nice to look at some, translational studies, some biomarker studies. If you're to kind of follow on the argument that, well, listen, it was successful in the JGOG study because most of these patients had upfront debulking surgery, it should be those patients that are benefiting from the weekly Taxol. I'm not so sure. I think that's, if we do think that these are really quite different patient populations, I think we need to be thinking about this when we do our future studies. Should we be studying all of these patients together? Because then we end up not really knowing how to interpret the results.
Thank you.
Okay.
Thank you very much.
No, I have one more.
Sorry.
I'm actually curious what you're doing now, because when you're when you see these patients and okay, you're not going to do dose dense, so you're going to do Q21, but you don't want to do Q21 because if you add BEV, that's better. But if you look at GOG 262, adding BEV is the same as dose dense, so we can't do that. So where do you go? Do you just give Q21 and then BEV for people who are not debulked or stage 4, or do those people go get dose dense and then the optimally debulked you give Carbotax BEV to, or do you
I was going to answer them, and you had a whole lot of other things. No, I think that Q3 weekly, and for the high-risk patients, bevacizumab would be a very reasonable strategy. I don't really know that GOG 262 answered that question of you can, BEV, because it wasn't randomized to say Bev versus weekly Taxol.
get
So,
that, yeah.
so I don't know that we can necessarily say, make that inference, but, that's, yeah. So I don't know, do you think that what would be the argument in favor of giving weekly Taxol now with the results of all of those studies?
It's hard to interpret. I mean, I think that's where we're all sitting and struggling, right? I guess one argument is that the Katsumata trial looked at overall survival, whereas the others didn't. And waiting for the one that actually compares dose dense to IP, like that to me is quite exciting. I want that result. Icon, I agree, the Icon 8 really puts a wrench into the way a lot of us have been practicing, but I don't think we have a clear answer.
Yeah, I mean, my view on this, and sorry, I guess you're kicking me out here, but I view Icon 8 being the largest of all of the studies. That holds some weight. I would really rather see, since the weekly regimen is more resource intensive, because it is, I have some concerns about quality of life based on the Icon 8, that I have returned to Q3 weekly Taxol. Perhaps when these 3 studies do present their long-term data and there's a difference in efficacy that is confirmed, then I might change back. But that's me. I think that's still a reasonable area for controversy.